Good morning, good afternoon, and good evening. Today we will be discussing peripheral joint mobilization techniques. Peripheral joint mobilization is one of the many manual therapy techniques that is done in physical therapy. So let's move on. Let's start with an introduction to PJM. What is it really about? What is this new term? What is it? It is the source of my nightmares. You see, PJM is lovable. You can like it. It's okay, but it can get complicated very quickly. For 1 second, you're just discussing, oh, the joint articulations, but then in the next second, you're like, oh my God, what grade am I supposed to give? You know. So it's very versatile topic, but it's a very important one actually. So again, it is a type of manual therapy technique done in physical therapy, and it can be used to treat pain in joints and, of course, as the name suggests, joint mobilization. We are trying to address joint impairments. There are two myths that surround PJM. PJM is a sole treatment. That is a big no. It is not a primary intervention, but it can be a preparatory technique before the patient is applied a certain intervention. So, for example, if you want to do stretching for this specific patient and they complain, I'm sorry, it really hurts, especially in my joints, I can't move it. You could first introduce them to PJM, apply some techniques, and then, depending on their response, you could progress the treatment or maintain the current type of technique that you're applying, and so on and so forth. Secondly, PJM is an exercise? Also, no. Since it's not a sole treatment, it's also a very passive motion. The patient is in a relaxed and comfortable position, only the physical therapist is the one performing the motions. There is no active contraction of the muscles, no movement from the joint except the ones done by the physical therapist. So it's not exercise. Okay, so we know what we're getting into. So it's joints. Okay, I get it. It's about joints. When can PJM be used? So there are two very important things we have to remember. Number one, have I examined the patient thoroughly? Meaning, have I looked at their chart? Have I read everything? Have I interviewed them and gathered a history? Have I collected the necessary data? And have I also performed physical examinations, musculoskeletal examinations on the patient so I actually know what I'm looking at? Secondly, have I actually provided a proper diagnosis? Am I confident that the diagnosis I've provided is actually true? And is it certain? I'm not stepping into new waters here. Like I'm certain, yep, this is the condition the patient has. Then yes, we could consider doing PJM first. But again, this depends on a lot of factors, patient response and yada yada yada. But the important thing is it's a joint mobilization technique, and you have to be certain of your diagnosis before you considering it. So before we actually get into PJM, there are very two vital terms that you have to remember, or we'll be reviewing: arthrokinematics and osteokinematics. So we look at the first two syllables of these words. Arthro means joint, or it's very similar to the term joint. Basically, arthrokinematics refers to the movements within a joint capsule, between articulating surfaces, and so on and so forth. Osteokinematics, on the other hand, osteo means bone, specifically bone shaft. So this refers to the movement visible within the bone shaft. I will be discussing arthrokinematics at a deeper level later on. But I can provide an example for osteokinematics so you can really see the difference. Examples of osteokinematics could be shoulder flexion, hip internal rotation, ankle plantar flexion. So these movements have one thing in common. They are visible to the human eye. You could observe them. if you're just looking at the patient performing the movement. Arthrokinematics, however, is only visible through the joint. So you can't really see it, physically, like manifest. Like, I mean, it is happening, but it's deep within the structure, so it's not as visible to the human eye as compared to osteokinematics. Anyways, I'll be discussing more about that later. Let's move on. Definition of terms. So here are just some terminologies that I can introduce so that you would understand what does PJM actually mean and what does it, encompass. But this doesn't really include everything about PJM, alright? It's just like an overview, basically. So we have mobilization in the name of the technique. So what does mobilization mean? In some books, PJM is actually referred to as peripheral joint manipulation. Other books has peripheral joint mobilization. But essentially, they're pointing at the same thing. It's basically applying different types of mobilizing techniques to joints. Again, the word mobilizing, what does it even mean? It's just movement. You're applying certain movement to a joint. The PT is applying movement to the joint. So, for example, if you're pushing against two joint surfaces, you're, you know, compressing them. That's compression. That's a mobilization technique. You're distracting them, meaning you're pulling them away. That's a mobilization technique. So mobilization and manipulation techniques, essentially they're kind of the same. Later on, in the very end of this long lecture, I would be discussing the grading system because there is a grading system. I know it gets complicated. Yeah, anyways, that's our problem for later. So mobilization techniques depend on the speed and amplitude at which you apply them. Example, grades can differ if you're applying at a faster speed or if you're applying at a slower speed, if you're applying with more pressure, with less pressure, and so on and so forth. High velocity thrust is very self-explanatory. I don't even know why I included it here. It's just basically high thrust at the end of the pathological limit of the joint, not ROM. We were talking about arthrokinematics, okay? Just the joint space, the joint capsule, you know. And self-mobilization is also you can see that these are all very self-explanatory. Like based on the names, you could understand, that's what that means. Self-mobilization is just part of a home exercise you could give to a patient. But one thing to note here, it is not the same as passive range of motion, which you can teach the caregiver of the patient to do it to the patient themselves. That is not allowed, or at least it's not really advisable because PJM is it depends on the skill set of the physical therapist. So it's something that you should get more of a licensure or some proof that you can perform PJM techniques, especially the more difficult ones towards a patient, because it takes time, it takes effort, experience, exposure if you apply it to a patient. So you can't just, okay, ma'am, I'm gonna teach you PJM. You're the caregiver of this patient. You could do it when they're home. No, you can't do that. No, don't do that. So self-mobilization, these are just home exercise programs that mostly focus on compression, distraction, but not really the more complicated ones. So I just said all those, just introduce the terminologies related to PJM, especially mobilization. Next, the joint. So if you've taken up kinesiology, you might be familiar with these joint shapes. Joint shapes in PJM mostly we focus on the ovoid versus the sellar, or also called the saddle. So the ovoid, if you remember, we have two types of bone surfaces, right? Concave, meaning it's like a cave, it's like a curve, or a convex, which is like a protrusion. It's like an O. For example, in the ovoid, usually ovoid joint shapes have one bone surface as concave. You can see there's a C. The other as convex. So I remember ovoid by thinking, oh, convex, concave, ovoid. Oh, one of them is convex, the other is concave. Essentially, this also applies to sellar. You know, every bone surface, every articulation has one concave, convex. But the difference in sellar is that it differs in which direction the joint is moving. Yes, I told you it got very complicated. So I'm gonna be explaining this later because it's not really understandable with this picture right now. But basically, depending on which type of movement you're doing in the axis, for example, if it's in vertical or horizontal, the bone surface that is concave and convex differs. So perhaps in one direction, in the vertical axis, bone A could be concave, but in the horizontal axis, bone A could be convex. Yeah. So that's why it's called saddle, because it's like saddle-like. But I just remember it because of S here. S. That's an S, right? S. Yes. Okay. Let's move. So here's an example for you to apply. So you could try and guess. This is the elbow joint, humeral ulnar joint. So we have the humerus here, and it's going into a flexion momentum and extension momentum. So which do you think? It is ovoid or sellar? Okay, I'm gonna say the answer now. You can pause the video if you need more time. If you answered ovoid, you're actually correct. If you answered sellar, I'm gonna explain to you why it's ovoid. So the humerus, humeral ulnar joint, the elbow joint, is an articulation between the humerus, the humeral head of the humerus, and the concave surface of the ulna. So it's like a spoon here, you see. That's why it's ovoid. Only one is concave and one is convex. And in the elbow joint, it can only perform elbow flexion extension, right? You can't really perform rotation just like in the knee joint where the tibia can rotate. No. In the elbow, it's just flexion extension. Simple. That's why it's ovoid. It's only one movement in one direction in the vertical axis. And the only one moving is usually the concave here. The ulnar. That's why it's ovoid. This is the ovoid. Next, another example. Oh, this one's a tricky one. So, do you think this ovoid is cellular? Let's say the answer now. So, you can pause the video if you need more time. If you answered cellular, that's correct. If you answered ovoid, I'm going to explain to you why it's cellular. So the sternoclavicular joint is responsible for motions like protraction, retraction, meaning moving your clavicle forward and backward, and also elevation and depression, meaning moving your clavicle upward and downward. So in the horizontal axis, which is protraction, retraction, right? The one moving is always the clavicle, but it is concave in the horizontal axis. You can see here, so it's concave, it's convex. However, in elevation depression, it moves in the vertical axis. So you can see the direction moves, the direction changes, the direction of the movement changes. So it elevates and depresses. But this time, it's the concave surface of the clavicle that moves, not the concave. Get it? That's why it's a cellar. So it gets complicated. But my tip to remember this is usually to just imagine a cross. Right? And you could just memorize like one bone. Okay, the clavicle has a cross, and it's concave, convex. And basically the sternum is just, or the manubrium of the sternum is just the opposite of that. Just imagine a cross, memorize just one bone surface, and you can just, logic your way to figure out what's the other one. Oh, we've actually finished the first part. So I hope you did understand. I think the most complicated part in this introduction would be definitely the sternoclavicular joint and the ovoid and cellar shape. So if you need to study on that more, you could read on in Brunstrom's Clinical Kinesiology. That's a book. Or you could also just check online, just check some images. You could practice. But yeah, this is the introduction to a peripheral joint mobilization, source of my nightmares. But I hope you learned something today, and I will see you in the next part.